The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. Welcome back to the Virtual Curbside. This is our monthly episode 4, where we get to ask our speaker all the questions that we've gotten from our episodes for the month so far. And by the way, thanks for all your questions and feedback. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Attention pediatric healthcare professionals. Are you ready to hear the latest insights on pediatric care? Sort of like you hear on the Virtual Curbside. Join us for the 47th Annual Common Problems in Pediatrics Conference happening June 3rd and 4th, 2025, all virtual. This premier event features expert speakers and cutting-edge topics, all from the comfort of your own home or office. Earn CME and MOC2, connect with colleagues, and elevate your practice. Early bird pricing ends April 4th, so don't wait. Register now at aaputah.org events. Welcome back to the Virtual Curbside. It's been our great pleasure this month to be able to talk to Dr. Anna Ermarth about celiac disease. It's been very enlightening, I think, on so many levels, and we're really glad that she came back this week to deal with some questions. Are you glad you came back, Anna?
I am glad. You were kind enough to let me look at these questions, and so I want to joke that you're going from virtual curbside to virtual rabbit hole in some instances.
Oh, good. That's our favorite kind of question.
You should change your practice name to Rabbit Hole Pediatrics.
I think I might. Let me check and see if it's already registered in the state. Before we get started, anything you want to disclose?
No disclosures this week.
Okay. Any exciting announcements?
Whether this was fortuitous or serendipitous or whatever the right term was, since we last talked, I was contacted by a European group to become a part of consortium to look at all the studies that have been done on our celiac patients who are diagnosed without biopsy, or how good those serologic markers are. And so I think it's a really exciting thing to point out that this is still going on and we're still a part of the game to improve diagnosis. And so, yeah, it's been, maybe this podcast was the thing that they heard. They looked me up as soon as they heard this podcast.
They listened to the podcast, said, she's the one.
Yeah. I was a nobody before this.
No, it's your great reputation that got you on the podcast. Let's start off with some questions. Let's dive right in. First two come from our mutual good friend, Lulu Waterhouse, who you trained with and I've worked with, and she's always asks insightful questions. So let's dive right in. Number one, I know tissue transglutaminase IgA is very sensitive and specific and is helping us have to do fewer biopsies. I've had one mom tell me her tissue transglutaminase IgA was negative, but the biopsy was positive. Do you think that the tissue transglutaminase would have eventually turned positive? Her son's always been underweight, but following his weight and BMI percentiles, and is a very picky eater, but has had a negative TTG IgA test. Should I continue surveilling him and testing him every couple of years? Mom doesn't want him to have to be scoped, but continues to worry about a false negative. Should I refer this kid to you?
That is great. I'll thank Lulu personally later for this, but it is a tough scenario. I have had parents come in and say, I was diagnosed, or an aunt was diagnosed and her blood work was never high, right? And I really stress that to diagnose celiac, you have to have that high serology in order to make the diagnosis. And the reason for that is because when we do these biopsies, there's other things that cause a similar look. And remember these words that we used to use called celiac sprue. I feel like we don't mention the word sprue, but that's really that slit gut event that happens when you have an enteropathy. And so there are other things that can cause that, whether it's an illness, a really bad GI bug can kind of, muddy that picture when you look at the biopsy under the microscope with some mixed inflammation. And again, it's hard for me to know what that parent's biopsy showed. So the first thing we always talk about is the IgA has to be high enough. And when you have selective IgA deficiency, I didn't really talk a lot about this in the other episodes, but the numbers are 1 to 3% of the general population have that. But if you have selective IgA deficiency, almost 30% of patients tested for celiac with symptoms. So again, you're throwing symptoms as another risk factor in there. could have the biopsies positive for celiac disease. And when treated, it does recover, and we know that. But out of all celiac disease patients, only 1 to 2% of celiac disease patients have IgA deficiency. So those are hard numbers to kind of wrap your head around, but it's still kind of rare. And so to her ask if it's negative once, how often should you recheck when you have a first degree family member that has this disease? I think as long as they're not falling off a cliff of weight or they have other, again, using the word sneaky symptoms that we don't quite recognize as classic diarrhea or malabsorption, then about once a year would be the most I would check. But at some point, when one parent has celiac disease, you still have to have both parents that have the HLA testing. So this might be a kid you do HLA testing in rather than throwing out there, these screening serologies.
Because then you are looking for a risk factor, and it makes sense since you're looking for a disease in a family.
Right. And so if the HLA or the genotype comes back and it's not DQ2 and DQ8, the ones we know that are linked with this, I think that helps put it to bed a little bit. You could say, well, the mom might have that, but my kid doesn't. I don't need to keep testing because we really can't, there's really no way we feel like they'll get celiac disease. So this would be a kid that, yes, genetic testing could be the next answer if they don't want them scoped. I don't typically scope for the reason to look for this, with the negative serology, but we also scope for a lot less for kids that don't have a risk factor of a high serology. So that isn't the wrong answer. And I think it's exciting that we can do a non-biopsy diagnosis. My husband is in sales. He's been in sales almost 10 years, and I'm probably the worst salesman. And so I kind of laugh because, this is what I'm supposed to do, right? As a gastroenterologist, is go around and scope everyone that walks in my clinic. And yet here I am saying don't scope. So, I think the nice part about it is we're being cautious and thoughtful, and we're not, jumping to conclusions too easily.
Right. And to our point on the last part of the question, sometimes these are kids who merit referral just because having another set of eyes on him may help establish whether or not you should push harder.
Right. And again, you're working in a team, right? We're trying to do our best to help the parents kind of know that there's both a pediatrician behind it and a subspecialist behind it.
And we're trying to be on the same page.
Correct.
Next question. I have a teenager with celiac who uses gluten test strips when she goes out to eat at a restaurant or friend's house so that she doesn't accidentally get glutened because she feels really sick for the next day. These strips and testing kits are pretty expensive, over $10 for each test. How accurate are these tests? If patients and parents are anxious about accidental gluten ingestion, do you recommend using those tests, or will they just increase anxiety and cost of managing the disease?
Bill, a lot to unpack. I first want to glutened. I've never heard that term.
Yeah, I like that one.
It's like, I don't like when you put an S on the end of celiacs. I don't know if I glutened. That's a hard German sounding term. So I looked a lot of these tests up when this question came through because I was curious. I actually had no idea how expensive they were. Are they accurate? Yes, right? This goes back to just because we can do something, should we? These tests, when I looked at some, I clicked on like 3 different ELISA technologies, Aventor Sciences. Pack of 25 is $375. A pack of 100 was $1,000. And I have a thinking suspicion most of these, websites are not as valid as they look. And so I think you need to caution parents who do this. The other thing that Lulu pointed out is she really feels sick the next day if she does one of these tests and feels like she gotten glutened. These tests can pick up as small as 10 parts per million in either food or liquid. We stop worrying about gluten in your food particles if it's 20 parts per million. At least that's what the FDA kind of regulates as the level you can have on a shelf of something gluten-free is 20 parts per million or under. I'm going down to my notes here. That's 0.00002 grams to wrap your head around. So again, these tests are catching something, but I don't really feel like maybe it's something that's going to damage the gut. Remember, you have to have gluten exposure for quite a while and over time to really make your cells flatten themselves out. And so to this question's point, I wonder if the really feeling sick is because you looked at a test and you saw that it came up positive, that in itself, what's the reverse of the placebo effect, right? Like that's pretty good. It makes you feel like you might have had something that truly isn't going to affect you. And then the other end that she says the parent is anxious. So I'm going to point out that We see a lot of kids that have ARFID, avoidant restrictive food intake disorder, on multiple levels. And this is another clinic I'm involved in. And I do worry that when you have something like this, where you're focused on it all the time, you're going to hand off some of that anxiety to your child. And we really want people to live a normal life, even when they're gluten-free, as much as possible. And so being reassuring as a pediatrician, I really think comes into play here. I think the first step is to not worry about these strips, to do your little bit of homework on what restaurants are good or not, to explain to a family, but soapy water on a stainless steel surface is going to take care of most of that gluten. And so there's really no reason that I think, unless you're chowing down on 3 brownies, that you should worry about testing everything that comes your way.
It seems like with an ELISA test too, how much of the meal do you have to sample to know whether you've found the part that is going to gluten you?
Yeah. And I have to say again, as pediatricians or physicians, not even pediatricians, we really should advocate for things. And these are things that aren't well founded. Kind of the supplement industry is the sort of take on these, I feel like. And so again, I think advocating to reduce something like RFID and not have you focus on micromanaging this is really key here.
Excellent. Next question is next two are a little bit of a refresher from things you've already talked about, but just to refresh our memory. What kind of surveillance is necessary for ongoing treatment and supervision of celiac disease? And which of these things should I be doing in my office?
Right. So definitely send them our way, even if it's a non-biopsy diagnosis. I really hope to empower people to do these tests and maybe have them understand the test a little better. But that doesn't mean you don't need to send them to us. Sometimes it's helpful for the parents to hear things a little bit differently from the specialist. And then getting involved with a dietitian right away is very much key. A lot of GI clinics don't actually have a dietitian in them, so you sometimes have to find that separately. And then the surveillance end after that diagnosis is about a 6-month to 12-month follow-up at least once. And I still advocate that they come back to the GI practitioner for this. And the labs we're doing are micronutrient labs. And interestingly enough, it's not at the time of diagnosis I'm worried about the micronutrient deficiencies. It's actually 6 months to a year into the diet, because I mentioned previously, a lot of these foods, because they're still seen as sort of altered non-FDA regulated foods, they aren't required to put in some of the supplements like folate and riboflavin and thiamine, and that we all take for granted in our food. So I check for those about 6 months out. So again, B1, B2, vitamin D, folate, and then I add on to that the thyroid test, the TSH with a reflex to free T4. And then if I'm worried about anything else, iron deficiency, sometimes that's recommended too. It's less likely to be iron deficient with taking out gluten, but just to kind of make sure you're looking at the nutrition. So those are the things that even in the primary care setting you could do. And once they've normalized, you don't really have to continue supplementing. So routinely supplementation isn't really a thing once your gut has recovered. Because once it's recovered and you keep out that offending agent, meaning gluten, you can really eat, almost anything, and you're going to keep those nutrients in your body. So I do recommend a multivitamin 6 months or to start at time of diagnosis. I do like the ones with iron, and some vitamin D and calcium I think is really good. This does affect your bone matrix. It really kind of helps with growth, especially in children getting near puberty. So vitamin D, calcium supplement, and a multivitamin. But again, once they're back on their growth track, they've hit some puberty markers, they seem healthy otherwise, and their TTG has come all the way down, then I feel like you can kind of stop checking those at a routine basis.
Sounds great. A question here about cross-reactivity with adenine in oats. Is that something I need to worry about?
So the oats question really kind of comes up because I think in 20, 30 years ago, when we were learning more about this in the world of gastroenterology, a lot of farmers did have oat fields right next to wheat fields, and we did realize that there was higher wheat particles in oat products, especially if they were also processed at the same plants. That has gotten better. Gluten-free products that are really certified separate. They don't have wheat processing in their plants. So that's the first thing that always comes up is what kind of oats can I eat? Does it have to say gluten-free certified? Sure, it can say that. It doesn't. I think the risk of cross-contamination is still pretty low with the way they're doing this now in the processing plants. But going on that, adenine, so this is a protein complex in oats that some people say they're still sort of reactive to. It does not cause intestinal damage though. So there have been some studies that are pretty interesting. In Australia, they did this where they gave escalating amounts of adenine in celiac patients that were on a gluten-free diet and had recovery of biopsies, so they knew their gut was intact, no damage. but they still would react when they kind of gave escalating doses of avenine. And when they looked at the blood work, I mentioned this in a previous episode, IL-2 was one of those inflammatory markers they looked at. They did the same thing in this study, and that IL-2 actually did go up. And so there's some evidence that maybe with larger amounts of this avenine protein, you get sort of an inflammatory reaction. However, when they looked at the biopsies of these celiac patients, it did not affect them there. So they actually did not have increased inflammation or any enteropathy in those biopsies. So there's still this idea of like, is it related or not? I kind of feel like it's true, unrelated, but that our guts, like we joked, it's the black hole. Like we're still kind of learning, how certain things affect us in terms of whether that's a sensitivity or a true inflammatory cause. So that's kind of the back end on avenine. Again, rabbit hole answer, but should you worry as someone that, like I mentioned, Lucky Charms is gluten-free, and I think it's still safe to eat most oats as a recovering celiac patient.
Okay, that part is actually very, very helpful. Next question. A lot of times we think about looking for celiac disease in patients who are underweight, but there are studies that indicate that some patients with celiac disease may actually be overweight. Is that something I should be considering when I'm thinking about somebody who is struggling with overweight?
Well, I think the first concern here is that we do tend to look for the underweight child and test them easily, right? Because
Yeah.
failure to thrive, malnutrition, that's our first line of pediatrics, essentially, of what we're trying to prevent. And so that's an easy answer. And then you get the overweight child that has a different milieu of symptom presentation. And I do think there might be a bias to say, well, they're overweight, they can't have a malabsorptive issue. And so don't count it out, Those patients definitely should be tested if they're having that symptomatology or just maybe something like fatigue. In my practice, I can remember one patient who came in with headaches, fatigue, and was slightly overweight. And I did both the thyroid testing and celiac testing, and both of those ended up being positive, meaning she had a autoimmune thyroiditis. And so what I learned from that is exactly what you're pointing out. We shouldn't discount someone who comes in with weight gain and still might have some risk for celiac disease. There was a study that was done more than 10 years ago now that the rate of celiac disease in a gastroenterology office or practice is about 3%. So I mentioned that it's like 1 to 2% in the general population. But as you can imagine, we narrow that field. And so it's going to be a little bit higher even for patients that don't present with classic diarrhea. And I think there was also a really good study even in the Irish population to show that in a celiac patient treated with a gluten-free diet, a lot of those kids then escalated to becoming overweight. And was there concern that we were just kind of letting them go and that the gluten-free diet is not exactly healthier? And we talked about this, how there is a lot of additives in gluten-free food. And I also wonder if, and I've seen this in inflammatory disease patients too, once we treat them, they feel so much better. They just go after it, right? Like they
Oh,
just
sure. Yeah.
eat everything in sight that they can because they've, been restricted for so long.
And they felt terrible for so long.
Yeah, and so it is a hard thing to then have to counsel a parent, well, your child was underweight and now they're overweight and now we got to counsel on that. But I imagine that that happens more than we've followed up in our studies on.
Next question is kind of a curiosity. I've talked to patients who said they could eat gluten-containing foods in Europe because the gluten there is different. Is there anything to that?
Oh, Paul, you've been around long enough that I feel like you know this phrase, but one of my colleagues always says the plural of anecdote is not data.
What if it is a firmly held belief?
Firmly held belief. So we talked about the Italians actually screen for this because they actually have the genetics. Almost 40% have the HLA DQ2 and 8 genotype. I can't explain that. I think it's wishful thinking. I have heard that in many ways as well. And again, it goes back to maybe their wheat source. Maybe they have a little bit of a less offensive wheat source. And the Calgary group above us have done excellent studies showing higher incidence of celiac disease there. And then we have higher incidence than has been reported in some even places in Europe. So again, what does that mean? Maybe it is the way the wheat is prepared there or the products. It could also be the products, right? So we always want to blame gluten. Why not think about how else is that made? Is it the gluten or is it the fresher butter or the, I don't know, less processed high fructose corn syrup? That's probably another issue. So I hesitate to say it's the wheat we probably should think outside the box a little and say, well, how else was that food prepared? But certainly if you have celiac disease, I would not go around just trying, European bread for that reason.
And it's not as if gluten enteropathy is unheard of in Europe.
No, I mean they were the originals that studied this. So again, that
Okay.
that again might be just, you had a great time in Europe and forgot about what you were sampling. I don't know.
All right. Here's an interesting one. Can you comment on the use of supplements that are supposed to help with intestinal healing in patients with celiac disease? My patients have mentioned turmeric and L-glutamine.
Yes. These are supplements. There are a lot of supplements, and they are not necessarily specific to celiac. So that hasn't really panned out. Let's start with turmeric. This is curcumin, which has a lot of anti-inflammatory effects. There are a lot of studies with inflammatory bowel disease with turmeric, especially trying to take supplements. And it seems kind of promising. There's actually, good studies to show that CRP biomarkers go down more quickly in patients who are supplemented with turmeric. And the toxicity level of turmeric is very low. You don't really have it doesn't really build up in your system. It's metabolized through urine, so it leaves the body if you get a little too much. I do think that's promising for things like inflammatory bowel. I don't know that there's a lot of research to say it's helpful in celiac. Again, when you turn over your cells in your gut, that's going to take 2 to 3 months. So if you want to do something in that 2 to 3 month period while you're waiting for the antibodies to leave your system, I wouldn't be against that because that turmeric has such a low kind of threshold for concern. L-glutamine. So glutamine is a little different. It's an amino acid, and this question specifically made me look up these facts today, but it is the most abundant free amino acid in the body, and it's stored in both your gut and your muscle. And so that's kind of where it hangs out. And so there's this idea that you need more of it to kind of help your gut recover when you're in your recovery mode. And there is some studies to show that patients diagnosed at the time of an inflammatory or celiac condition had lower levels of glutamine. But back to what I just said, it's stored in your muscle as well. So a lot of these patients already had reduced muscle bulk and sort of that malnutrition picture. And so I don't know that it's necessarily that we ran out of L-glutamine. It's probably just less available. The other rabbit hole I got to go down today with glutamine is that rats have shown the reduction of cytokines and TNF alpha when they rectally applied glutamine to rats given colitis. I have never heard of anyone doing this at home, but there's some promising rat research that hasn't gone on, and that supplementation of L-glutamine in pre-weaning Holstein heifer calves out of Indiana showed that at the end of their supplementation, neutrophils went down, which again we know is inflammation. Outside of that, I have no idea if this really helps in celiac disease. It might help you recover 2, 4, 6 days earlier, but it's not going to be a Hail Mary for anything else.
Then it does seem that the one thing is eliminating the irritant. And,
Right.
and then, I guess people want to try some. It sounds like there's not a huge downside to maybe supplementing turmeric and L-glutamine.
Yeah, not a downside.
There could be a big upside, but
Yeah, they have even looked at this glutamine when, short bowel patients and critically ill ICU patients, they've given it parenterally and it didn't really have to seem any effect. And even all those studies were in the late 90s, early 2000s, and there haven't been follow-ups. So I don't think it's kind of worth chasing. Is it going to hurt something? Probably not, not more than your pocketbook. Is it going to help? Maybe.
all right. How about other remedies that people have mentioned for use in intestinal issues? Things like apple cider vinegar, herbal teas, and colloidal silver.
This one, other remedies. So we're kind of teasing away from celiac disease because,
Well,
again,
sort of, but I think the issue here is that people want to have something besides the simple thing here.
improve gut health. And I am certainly not against that. I think that that is key to a lot of our well-being, even our mental health. I talked about the microbiome and how we don't know a lot about it, but I do have a feeling that yes, food is thy medicine, and that's key to a lot of things. Taking out additives, taking out again, my thing is high fructose corn syrup. If we can get that out of our American diets, we may not need GLP-1s. But to go back to this question, so colloidal silver, that's totally different than apple cider vinegar or herbal teas. This really is more toxic than helpful. And I think I would just want to get that across. Like if a parent is using this or a patient is using this, I really don't see any role for it. And the amount of toxic headlines that come up when you put this in PubMed is like never ending. You'll see a case report of colloidal silver ingestion and severe anemia, optic neuropathy from this, acute silver toxicity from an overdose. And so the threshold or the risk to this is way higher than I think any improvement with this. I also learned something.
You can even dye your skin.
Yeah, it gives you like a purple tinge. Almost like the how we used to treat thrush, right?
Yeah.
But the reason this got so popular is that these were put down into nanoparticles, and this was kind of new technology. And I think it's interesting, right? So it's a very novel thing, and they mentioned in a couple of these reviews I read today, microelectronics, catalysis, bioimaging, solar cells, inkjet printing, glass and ceramic staining have all used colloidal silver as like improvements in those things. What it hasn't been shown is to help things, but what it will do at that nano level is kill viruses and bacteria. So that's the thing that everybody holds on to is, well, if I get a GI bug, this will help me recover because it'll take away or kill those microbials. That's probably not true. And again, with this Finnish study did what we've done, and I listened to your episodes on mood disorders, and you guys go into nutrapharmaceuticals on that a lot or supplements. And this is kind of the same thing where in Finland, they did 14 most popular colloidal silver supplements off Amazon. And this was during the pandemic when people thought that, or still think that certain, veterinarian things can fix COVID. But when they looked at those most popular silver compounds, none of them had nanoparticles. And at its best, they were just like silver flakes put into water, which really don't do anything, right? So that's the first thing, buyer beware. What are you buying when you buy supplements? And this is where I'm going to go off the curb, but also use the curb as soapbox here is I worry about parents that buy these things and spend a lot of money on them when they're not useful. And so beware of things that sound too good to be true, right?
Fair enough. Last question is we just want to make sure that we have your recommendations for resources. We can post those to the show notes. Any tips for people when they're eating out or away at someone else's house?
Ask questions, ask questions. We talked about how cooking surfaces actually can get contaminated, especially when you sort of throw similar flours, pizza crust on the same surface as another pizza crust, and that all mixes in with wheat flour. So you got to do a little bit more research on restaurants. The best one is celiac.org. So this is the national kind of celiac advocacy group, and they have, you can do tons of deep dives on their website. They even have good patient and parent virtual groups that meet, webinar groups where they kind of get together and do more education. Our group here in Utah is trying to do that as well, where we try to engage both a dietitian and one of our nurse practitioners and do more education-based virtual training that way. So celiac.org is really kind of the only place to go. Another one I like on that site, I really like is their gluten-free candy list. So this is wonderful because you can get really confused with candy. And in Halloween time, none of those little bars or little candies have the label to say what's gluten-free or not. So if you're really not sure if your kid can eat one of those, go to the celiac.org gluten-free candy list. And they even have it organized by holiday. So Passover, candy and gelt at Passover, or Easter safe candies versus Halloween. And I did learn that certain candy manufacturers make their candy slightly different according to some of these holidays, for flavor preferences, I think. Yeah. So it's actually kind of seasonal, and you can find out the ingredients of like that season's manufactured candies. So that's a great
Super
resource.
helpful. Yeah.
Yeah. Here in Utah, again, we're the world of supplements here. And so one of the good things they put on is a gluten-free World Expo. And that website, I found out, has a Disneyland guide. So
Wow. Yeah.
yeah, I think you have to buy it, but if you're already going to Disneyland, why not? And you can get a guide to the restaurants at Disneyland that have gluten-free products for your child or for you.
That's great.
Yeah.
All right. Well, I think we've got a lot to think about here. Thanks so much for your time over the last month, and look forward to talking to you again at some point. Anything else you want to share before we're done?
Yeah, no, this was great. I really hope people learn something. I guess my last disclosure caveat is that, I stand on evidence-based medicine as much as I can. And I think I mentioned in the last episode that we learned our genetics through Jurassic Park. I really did not learn my genetics through Jurassic Park. But I think my kids think I did. So that's my millennial caveat there on that comment. I was like, oh,
Thanks for
sometimes
joining
these
us.
jokes don't come across
We
on
look forward
podcasts
to getting
like you
together
think
again
they
next
will.
time. The virtual curbside is available on iTunes or
So
wherever
I
you
did
find
go
your
to a
other
real
favorite
medical school. I
podcasts.
did not learn my
Be sure to
genetics
like us and
through,
subscribe. We want
Jeff
you to like us
Goldblum
both
in
because
that
we're
movie.
needy that way, and because that will
But
help
it's a
other
good start,
listeners
right?
like
It's
you
a
find us.
foundation.
Check out our website,
those microcredit
vcurb.com, for
books,
supporting materials,
they put a lot more out
schedules,
there
and
than
other
we
great
probably,
stuff.
expected.
The Virtual Curbside is an
We're trying to look for
educational
that piece of
production of the
amber
Utah
with the
chapter of
mosquito.
the American Academy
Yeah.
of Pediatrics.
Well, thanks
The
so much for
opinions
your time.
expressed
Hope we
in this
can talk to you
podcast,
again
while
sometime.
carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.